Welcome to the Smart Weight Loss Coaching Podcast. I'm Dr. Lisa Olson, a board-certified weight loss medicine specialist and certified life coach. In this podcast, I'll share fresh insights and effective techniques for incorporating mindset, habit change, and proven science into your life. Are you ready to achieve sustainable weight loss, wellness, and longevity? Then let's jump in and lose weight the smart way. Welcome back. I have a new client, let's call her Nicole, who started Zepbound, also known as tirzepatide, through her primary care doctor. Zepbound is the next step up from semaglutide, which was the first GLP-1 agonist to gain popularity for weight loss under the brand name Wegovy. It's also known as Ozempic for diabetes. Like most people, Nicole tolerated Zepbound beautifully, and so they inched up slowly on the dose each month until she started to lose weight at an impressive but safe rate. Things were going well initially, but then she had to reschedule her follow-up appointments with her primary care doctor a few times, and in a snap, 6 months had flown by. By the time she finally made it to a follow-up appointment, she had lost 60 pounds and was feeling somewhat weak and tired. She wasn't eating much at all, hardly any protein, and she wasn't getting any exercise. At that point, her primary care doctor felt uncomfortable continuing to prescribe her medication, so Nicole reached out to see me. My goal is never to have someone losing weight this quickly, especially without ongoing conversations about lifestyle modification, habit change, and especially conversations about preserving muscle, because dropping pounds on the scale is not the only goal. It feels amazing to lose weight and to feel great in your clothes, but the goal is to lose it in the healthiest way possible to avoid sarcopenia. Sarco means muscle, and penia means deficiency or lack of something. Not enough muscle is called sarcopenia. Over the past year or two, physicians in my field are starting to see a new problem we never imagined confronting. Too much success with weight loss medications, and sometimes too much success too quickly. The new GLP-1 agonists like Wegovy and Ozempic, the combined GLP-GIP meds like Zepbound, and the new triple G meds that are coming down the pipeline soon are all making us face the impact of profound and often rapid weight loss on body composition and health. Let me say on a side note that I'm an advocate for using these medications when appropriate, and I do prescribe them, but we absolutely cannot prescribe them without close follow-up or there may be problems. This honestly wasn't the case with our older weight loss medications that worked more slowly and gently and led to less total weight loss overall. When we lose weight, we inevitably lose both fat or adipose tissue and lean tissue, most of which is muscle mass. I've read articles talking about people losing as much as 25% of their weight loss from lean tissue, but at a recent Obesity Medicine Association conference, the news was worse than that. Researchers quoted numbers like 25 to 40% lean mass lost. So think of it like this. If someone loses 100 pounds, which is obviously a tremendous amount of weight to lose, 25 to 40% of that might be from lean mass, most of which is muscle. Now, most people on these meds aren't losing 100 pounds, but plenty of people are losing 50 pounds. That means as much as 20 of those 50 pounds lost could come from muscle. Yikes! You can see why this is a serious problem. Before we do a deeper dive into Nicole's situation with both weight loss and muscle loss, let's first talk about body composition and what happens when we have a low amount of muscle relative to our weight. Many of us struggle with carrying extra fat tissue, also called adipose tissue, complicated by low levels of muscle. This happens all the time, whether people are taking weight loss medications or not, although not everyone who carries excess weight is muscle deficient. I've worked with plenty of people who are overweight and also very strong with plenty of muscle. But that's not what we're talking about today. Sarcopenic obesity is defined as a decline in muscle mass and function, along with an increase in adipose or fat tissue. Not enough muscle, too much fat. Usually, excess fat tissue will stimulate the growth of bone and muscle. But when this doesn't happen, we have an imbalance in our body composition with less muscle tissue relative to our adipose tissue. About 1/3 of women age 60 and up have sarcopenic obesity. 1/3! The rates are even higher among women who have prediabetes, diabetes, or MASLD, what we used to call fatty liver disease. We also see more sarcopenic obesity in older women and in those who have had bariatric surgery. Research tells us that having sarcopenic obesity is far worse for our health than having either obesity or sarcopenia alone. And by the way, when I talk about obesity in this episode, I'm adhering to the old definition that cuts off at a body mass index of 30. For women, that means if you're 5'3.5", which is the average height in the US, and 172 pounds or more, you technically have the disease of obesity. Please don't make that mean anything about you other than you fit this imprecise textbook definition of obesity that doesn't take into account your muscle mass or your metabolic health at all. The body mass index doesn't even differentiate between men and women. The average height of a man in the U.S. is 5'9", and a healthy weight would be anything under 169 pounds. If that average man reaches 203 pounds or more, he fits the BMI or body mass index cutoff for obesity. We have a new definition for obesity, which is much more nuanced and takes into account metabolic health. But for the purpose of this conversation about body composition, meaning how much fat tissue versus muscle tissue we have, we're going to use a BMI or body mass index of 30 as our cutoff for class 1 obesity. Please do me a favor. Don't judge yourself. And I promise I'm not judging you either. You don't need to own this label. In a study last year published in JAMA, Journal of the American Medical Association Open Network, researchers showed data looking at body composition in people with excess weight and measured their hand grip strength, which is a reliable way to measure muscle function. Basically, you squeeze a device with your hand and it measures the strength of your hand grip. Those with the lowest muscle function and least amount of muscle tissue had the highest mortality rates, meaning they were the most likely to die during the study period. This research correlating higher all-cause mortality or lower survival rates with sarcopenic obesity has held true across many studies published in recent years. So what is it specifically that happens to us when we have sarcopenic obesity? Why does it matter if we carry excess fat tissue while having low muscle mass and strength? I will tell you as soon as we hear a quick word from our sponsor. Haha, just kidding. It's still me, Dr. Lisa Olson, founder of Smart Weight Loss Coaching. If you're as focused on your health as you are on the scale, you're my person. In my online program, we'll help you establish healthy habits for weight loss, better health, and longevity. For those of you who have looked at our website before, you'll be excited to see that you no longer have to commit to a 3-month program to join us. If you'd like to learn more about our affordable monthly membership, head over to smartweightlosscoaching.com. And we're back. I was about to tell you why it matters if we have lower muscle and higher fat tissue. Falls. Falls are the leading cause of both fatal and non-fatal injuries in older adults. And guess what, folks? The risk doesn't start when you're 80. The risk of falls begins to go up in your 50s, and sarcopenic obesity is the leading risk factor for falls in postmenopausal women under the age of 80. Women at every age should be working to maximize their muscle strength in order to minimize the risk of falls when they're older. Men too, of course. When we look at women with sarcopenic obesity, they're far more impaired in their functional activity than those with obesity alone. particularly if we look at something as straightforward as going up and down stairs. Obesity reduces our ability to do specific strength maneuvers like stairs, and sarcopenia makes it even worse. But those who perform the very worst on muscle-specific tasks like stairs are those with sarcopenic obesity. These are the people at greatest risk of falling. How else does sarcopenic obesity impact our health? It increases insulin resistance, which causes weight gain and can lead to type 2 diabetes. Here's why sarcopenia makes insulin resistance worse. 80% of glucose uptake occurs in muscle cells. If we don't have enough muscle, we don't take up and use our glucose, which is the fuel we need to create energy. There's fuel floating around in the bloodstream, but the body isn't using it because it resists insulin's attempt to deliver fuel to the cells. This is not good. Too much blood sugar floating around damages our organs, our eyes, our kidneys, our heart. But before we talk about solutions, let's learn just a little bit more about the impact of too much fat and not enough muscle tissue on our health. Not only does sarcopenic obesity increase our risk of diabetes, but it also increases our triglycerides, a harmful type of cholesterol, and it lowers our HDL, which is a protective form of cholesterol. In one study published in 2024, they looked at women aged 45 and up and found that those with sarcopenic obesity had a 52% higher risk of cardiovascular disease than those without. More heart attacks and more heart failure. The most meaningful health outcome study I read this week was published in Clinical Nutrition in 2022, looking at brain health, meaning how well we think, behave, and remember things. In this study, those with sarcopenic obesity had a profoundly increased rate of both mild cognitive impairment and full-blown dementia compared to healthy controls and to those with either obesity alone or sarcopenia alone. I'm going to say that one more time because I think this nugget of information should drive all of us to do a plank or some lunges or squats right about now. If you have an imbalance in your body composition with too much adipose tissue and not enough muscle, it impacts your brain function. Your brain function, people. Pay attention to this. Let's move into prevention and treatment of sarcopenic obesity. First of all, whatever your situation, it's never too late to make changes. I'm serious. Working to preserve your muscle mass and function as you age is incredibly important, and you can absolutely get started on that today. I want you to believe that it's possible. What I don't want to happen is what I fear may have happened with my client, Nicole, who lost a lot of weight really quickly without adequate coaching to minimize the amount of muscle loss she had when she lost weight using medication. When someone sees me for weight loss, my goal is to minimize the muscle loss while maximizing the loss of fat tissue. It's a complicated dance to manage nutrition and exercise to accomplish this. Medications can be a vital part of treatment, but they can accelerate problems if we're not careful. If we can reduce fat mass while preserving muscle, we can increase someone's functional capacity and quality of life. There are two main levers we can pull to manage our muscle mass. One is getting adequate nutrition, especially protein, and the other is to do resistance training. There isn't one precise answer that all specialists agree upon for how much protein a person needs to prevent or to treat sarcopenia alone, obesity alone, or sarcopenic obesity. But if you're dealing with sarcopenia, we do agree that you would benefit from a higher protein intake, possibly as much as 1 to 1.2 grams per kilogram of body weight per day in divided doses. I'm going to invite you to skip the math and I'll jump straight to the answer for you. Remember, our average woman who's 5'3.5" and weighs 172 pounds, if she has sarcopenic obesity, she might want to aim for around 28 grams per meal over breakfast, lunch, and dinner. I'm rounding, but if you love math, join our program and I'll be happy to walk you through the details. For most women, 28 grams of protein 3 times a day would be a lot more protein than they're used to eating. But that's the point. We need to provide the body with an abundance of healthy protein in order to repair, maintain, and even build muscle. Making that same calculation for the average man with sarcopenic obesity and a BMI of 30, he would want to eat about 34 grams of protein 3 times a day. If these numbers seem high to you, I get it. I think they're high too, because these numbers aren't geared toward weight loss. They're geared toward optimizing muscle mass and function. I like to see where a person is starting and to adjust from there. Let's say you're our average height woman with a BMI of 30 and you're getting only half a gram per kilogram per day of protein, which would be 13 grams for breakfast and for lunch and for dinner. That's actually not bad, but it's not enough if you have sarcopenia. I'd start by having you bump up to something like 15 to 16 grams per meal, and then 18 to 20 grams, and see how that goes. We don't have to double your protein intake overnight. What kind of protein? Well, please steer clear of protein shakes and powders, unless you have a strong reason to need those, like bariatric surgery or some malabsorption issue. Most protein shakes and powders are made with ultra-processed ingredients, so check the ingredient label, not just the front label with its aspirational marketing claims. I like to focus on plant protein, including that found in lentils, beans, edamame, chickpeas, quinoa, seeds, tofu, and nuts. Even steel-cut oats and some vegetables contain modest amounts of protein. Of course, you can also consume fish, eggs, Greek yogurt, cottage cheese, and other healthy animal sources of protein too. In order to prevent or treat sarcopenic obesity, we have to do more than just eat a healthy diet with ample protein. We also have to use our muscles to make them stronger through resistance training. There was a terrific study, a meta-analysis published in 2023. They looked at 11 different randomized controlled trials to see the impact of resistance training on adults aged 50 to 70 who had sarcopenic obesity. Here's what they found. Although there was no change in body mass index with resistance training, there was a significant decrease in percent body fat and a significant increase in percent muscle mass, muscle strength, and walking speed from resistance training alone without any other intervention. In another study from Brazil, older women who are overweight and inactive were assigned to either a control group or a group that did either 1 or 3 sets of resistance training exercises. During the 12-week trial, the women in the exercise group did their resistance training 3 times per week and did 8 different exercises of 10 to 15 repetitions each. Those who did 1 set finished in about 30 minutes, and those who did 3 sets typically finished in approximately 50 minutes. As you might have guessed, there was a significant increase in muscle strength and a decrease in body fat percentage in the women who did 3 sets 3 times a week compared to the control group who weren't assigned to resistance training. That's 50 minutes 3 times a week to get the most benefit for your body composition from resistance training. All right, friends, we've gone way deep into the science of sarcopenic obesity today. Thank you for hanging in there with me. I could have talked about the data for hours. Hopefully, it's inspired you to think about your NBA, your next best action that you'd like to take today in order to live healthier, longer, and at your happy weight. Remember, you don't have to do it all. Just pick one small idea from today's episode and give it a go. Thanks so much for listening. If you'd like more support during your smart weight loss journey, check out our group coaching program at smartweightlosscoaching.com. Until next time, stay well and stay smart.